As a reminder, this podcast covers sensitive and sometimes difficult medical topics. Listener discretion is advised.
Hey everybody, welcome to episode 4 of No Referral Required. We're all here. This is Courtney.
Hi, it's Mandy.
And it's Lara.
And we're back with episode 4. So excited to be here. And we have a great guest with us today. As somebody, I am fascinated by what you do because I haven't done it in a while. So anyway,
Things change.
I know,
And
right?
We'll find out.
Let's find out what.
Yeah, we are here with Trenia, who's a native Tennessean and an OB-GYN here in this area, and started her career doing what we call full scope OB-GYN, seeing patients in clinic, seeing patients on the labor floor, doing GYN surgery. But in the last few years has changed course a little bit with what she's doing, and we would love to hear from you. Tell us a little bit about how your career has changed over the years.
I started out in full scope obstetrics and gynecology about 17 years ago, and I did that for about 13 years. And about 6 years ago or so, I decided that I wanted to specialize more in just obstetrics. So now I'm doing obstetrics hospitalist work, which is much more of where my passion is.
That's great.
What does that mean? What is an obstetrics that does hospitalist?
So there's two different types. There is a laborist and there's a hospitalist. A laborist just works on labor and delivery and works with delivering babies in different fashions. C-sections, vaginal deliveries, takes care of women who are in labor. A hospitalist can still include gynecology in their scope of practice as well. A hospitalist covers women's health care.
Okay.
I guess you would say when other people aren't around. So I will do obstetrics. If there is an ectopic pregnancy, I might cover that as well. For me, myself, I work in a large academic center, and so there are most of the time gynecologists nearby. So most of my practice is in obstetrics.
Okay. Interesting.
So what has this looked like for your life? So you used to have clinic where you'd go in the morning, see patients all day, and then you'd maybe have a call shift at the hospital. How do things look different now?
So for me, it's probably a lot different than other places because I'm the only hospitalist at the practice that I work at. And there are full scope obstetric and gynecologists that work there. I'm the only hospitalist, so I'm the only one that only covers on labor and delivery. My weeks are very different. I don't really have a set schedule. I do have one day that is a set schedule for me, and that's that I work every Sunday night. But every week looks a little different for me. Some weeks I might work 3 nights a week. Some weeks I might work 2 days and 1 night a week. So my schedule does change, but that's
depending on the patients that need care.
Or the other doctors.
It's more dependent on the other doctors.
The gaps.
Oh, okay.
And their coverage.
I fill in gaps when people are on vacation. I think this is new in our practice, and so we're trying to add more hospitalists. I think it's hospitalist obstetric work is new across the country, and it's growing. And it's becoming very popular, and it's nice because there are people that can do just the obstetrics part, and people that can do more of the gynecology part. So instead of doing full scope practice, you can specialize a little bit more in what your passion is.
Okay. So Trenia, you're doing shift work now.
I do shift work, 12-hour shifts.
And you do 3 of those a week, 4 of those a week?
I would say on average 3 to 4 a week.
Okay.
Some weeks I might do 5, some weeks I might do 2. It just depends on it. But on average, it comes to about 3 to 4 a week.
And your practice requires flexibility so that you can fill in the gaps essentially for all the other people that cover
until we get
delivery.
If we get a full scope of 5 hospitalists, we can get more of a set schedule. But for now, with just me, I fill in more gaps, so it's more variability.
So that would be the goal, would be to have 5?
Correct.
Is that based on the number of people that come in, I'm assuming? Or how did 5 become the number?
Well, I think 4 or 5 is the number. I think it's just based on how big the practice is. So we work in a large academic medical center, and so we're very busy.
Yes.
Right now, the obstetrics and gynecologist providers cover labor and delivery with us, but in the future, the hope is that more coverage is covered by just the hospitalists.
Okay. How do you feel about this? How does this work in your life, kind of in your personal life? Has it been better? What are your thoughts on
Family
impact
life.
on?
So much better.
Okay. She was emphatic about that.
I have always loved medicine. I have always loved science. I've always loved being a doctor and doing what I do. I very much had more of a passion for OB and working with obstetrics than I did gynecology. I liked gynecology. I was good at gynecology, but I deep down inside, when I would wake up in the mornings that I was going to labor and delivery, there was an excitement in me. And I didn't always feel that with gynecology. And,
It's the opposite for me and Lara.
Right, exactly.
I kind of walk by L&D and I'm like,
Shy away.
That's what the world makes
we're all
the world
in
go
our
round.
right place.
Yes,
we
good.
need all of us.
Thank God for you, Trina.
That's right.
Yeah.
But that's, I forgot where we were going with that.
Just
that's
how it's
how
works
it's
different.
been your life.
Better for
It's
your-
much better.
So
Much
you feel like
better.
you're living your passion a little bit more. It sounds
Much
like.
more. I
Yeah.
think trimming away things that are were not. I was not as passionate has been much better for me. I no longer do as much clinic, which I didn't enjoy as much. I have less things to follow up on
Right.
in my
Results
life.
and things like that.
Results and messages and questions and things like that, which sort of took over my life for a long time and felt like a burden. I no longer have that. So a lot of that has been lifted off of me. And it's like Mandy said, it's shift work. I get up in the morning, I pack my lunch, I go into work. I know I'm going to get off in 12 hours and I'm going to sign my patients out. And it's sometimes when I did clinic work and gynecology work, I felt like I took that home with me a lot. And I always wondered, am I doing the right things? Am I following up the way I should? And sometimes, frankly, I was just so busy that I felt like I might be missing things. And the beauty of the world I live in now is I do my 12 hours. I have patients on the board. I sign them out to the next person, and I know that person's going to take care of them until the next time that I come in.
Yeah.
And so that's, for me, a huge weight lifted off.
So obviously this is great for you as a provider. Should I say provider? That's such, people have strong feelings about the word provider.
Why?
As
What
a
are the
physician.
feelings about provider?
Oh, we'll put a pin in that.
that's a
I'll
whole
get
thing.
back to that.
That's a big thing.
Yeah, that's a whole thing. So I'll just move on and say physician. But that it works very well for you in just mental health and all of the things. And I can totally see that. How have the patients reacted to that? Have you noticed any hesitancy or any concern, or do they...
I haven't noticed any concern at all. And what I will say, and I feel like I am on obstetrics and labor and delivery more than anyone else is. And my knowledge about obstetrics has grown dramatically just being there.
Oh, that's so interesting.
My skills as a surgeon in obstetrics has grown dramatically. My ability to perform some of the procedures that we do in obstetrics, like forceps and vacuums and repair of high-level perineal tears after vaginal deliveries, I would call myself an expert in that. And I feel like my confidence is there. So for me, I think that it's been very well received. I know that the nurses always recommend me as far as who would you want to do your surgery, who does more than anyone else, and that's going to be me because I'm just
You're there.
You're there.
I'm there
doing
more
it,
than anyone else.
Malcolm
So-
Gladwell's 10,000 hours.
Yeah, I was going to say that the high volume.
Yeah.
You make such an excellent point that the one who's doing forceps every week
Right.
is the one that's going to have the lowest
Yeah.
risk of outcomes.
Absolutely.
Yeah, I could see with the change of the old model where you saw your own doctor in clinic all the time and then your own doctor delivered you. And there's some nice things about that. But when you compare, also there's some nice things about having the high volume person doing your delivery,
right. Yes.
There's a lot of things that I feel very comfortable doing that other people that aren't there very often don't feel comfortable doing.
So when you walk into a woman's room that's in the middle of labor or whatever, and you're taking over, you're signing in to her care, walk me through, how do you approach that? Because a lot of these people you've never met, right? You've never seen them before, or how do you... I'm just putting myself in the place of a laboring mom and being like,
new face.
Who is this? I don't know. Yeah. I'm in the middle of the most excruciating, horrible, feelings that I have had, hoping that everything goes okay. What works for you?
Well, what I'll say is I think medicine today and obstetrics and gynecology today is leaning more towards that. I think that the time of I have my obstetrician and that obstetrician is going to deliver me is not as popular in
so people are expecting it maybe more like
I think in our practice we try to introduce people to that you are at a large academic medical center, you are probably going to see more than one physician, more than one midwife. You're probably going to have learners involved. And I think we try to tell people that before they come to the hospital. So hopefully they're expecting that. We work 12-hour shifts, so I may come in and be with a woman for 6 hours, and then my shift is over and I have to introduce another physician. But the studies have all shown and supported that 12 hours working on labor and delivery is about as long as you should be there. That's your, when you start to get tired and when mistakes start to happen, comes after the 12-hour mark. So we try to do that for patient safety as well as, like Mandy said, the health of us as well.
Sure.
So it's a win-win situation in the end.
There's so much talk about physicians leaving the field and our specialty, and I think more attention on what are the changes we can make that allow people to stay longer, and so things like 12-hour shift caps.
Right. There's so many studies and so much research over the last 5 to 10 years on the wellness of physicians, which was never looked at in the past. And that's huge for keeping people engaged and happy and have a good work-life balance.
Do you follow this laborist or hospitalist trend? Like, do you know what's happening over the years as far as the number of positions that are available or like recruiting? Like, do you see job posts for this frequently? Do you know? I'm curious if you're aware of like what's happening. Is it growing exponentially? Is it everywhere that it's growing? Is it in certain places that it's growing more than other places?
It probably started about 10 years ago, and it was a slow start, but it is growing exponentially now. It is the healthy life-work balance in the communities is starting to become a priority for people, and people are seeing what having a hospitalist at their hospital can do, and more practices are starting to hire hospitalists. And I would say that it is national now, whereas it was small to begin with, but it has definitely grown exponentially. And I think it's growing even more now. I think it's becoming bigger and bigger and bigger.
Sure. So if you were entering med school today and wanted to go down this path, now that it's something that can be, gotten to, and in your education, what do you do? Do you do anything differently, or do you have to practice, quote, regular OB-GYN first?
It can be a little bit different. Now, you have to train as an obstetrician gynecologist. The residency program is OB-GYN.
Okay.
And so you train both. Now, there is a fellowship that is fairly new over the last few years that is OB Hospitalist Fellowship.
Oh, okay.
And it's usually a 1 or a 2-year fellowship, and it is just to train as an OB.
Is that very rare, or is that across the country? Like lots of...
How many are there? Do you know how many fellowships there are?
I don't know how many fellowships there are.
Okay.
I know it is growing. There... I don't know how many there are.
Okay. That's
okay. But it is growing. But it is something that people are becoming more and more interested in. And even I work with residents now, and I do have residents that express a desire to do that. more and more, I see it more and more.
Yeah.
You've persuaded me that it's good. Because my initial reaction is like, what?
Why would
I
want a
want
stranger?
my doctor to, be the one to carry this through.
Yeah.
But now the more that you say it, I'm like, okay, yeah, no, that makes more sense. I want the most qualified
The one who's
person
there all the time.
taking
Yeah.
care of everything.
Yeah.
And my doctor follow, you go and see them after and all that kind of stuff. So you do no, I think I heard you say, you do no follow-up after the fact. Like you don't, the 6-week post, all that stuff, a patient would just go back to their regular
Correct.
OB-GYN. Okay.
Correct.
Okay.
Now, I actually do have one clinic that is called a perineal clinic. So
Okay.
I do follow patients that I do the higher level tear repairs on.
Okay.
And so I will follow those in clinic.
Okay.
Which is kind of a new concept, and it's been great to follow those patients as well. I think it's been good for me because I've learned a lot on how those repairs do over time.
Oh, yeah.
And what they should look like. And
Like immediate feedback, almost.
correct. And then it's also been nice for the patients because I see so many of them that I can tell them things that they should do and things that they shouldn't do and things that they should expect.
Right. Okay.
I
That's
always
great.
thought there should be someone who specialized in what they call the fourth stage, which
Oh.
is the postpartum
Yeah.
time.
Yeah.
And just did that as their focus and saw women and talked about all the things that we just run through in 15 minutes, which really need probably an hour.
Yes.
Mood and breastfeeding
Yes.
and sleep and intercourse and birth control and healing of lacerations and just all the things that back to normal screening and expectations and pelvic floor PT, all
Right.
the things that
Right.
get completely glossed
It's
over.
2 hours. I don't think that's one. You just listed a million things.
But just to focus
I will
on
say
that.
this. I think there has been interest in that. And I think that we used to see people at 6 weeks postpartum. And that was the first time you saw them. And I think recently we've started adding 3-week visits for people. And for just that, to go about like, how are you doing? How is your mood? How are things feeling? How is your family handling this? How's breastfeeding going? And to hit all those earlier on. And it helps to decrease some of that postpartum depression and some of that anxiety that people may not know they should ask those questions.
Yeah.
Right.
Right.
Yeah. You
What
don't
a
wanna wait
time to
till
be
6
alive
weeks.
here. It's amazing.
You've seen a lot of change in the field of OB-GYN. We talked about several changes just now, but what are some of the other big things that you've seen a shift in OB-GYN?
So, I started my practice in obstetrics and gynecology, but I'll focus more on obstetrics. What I will say is I think that when I first started practicing for probably the first 5 or 6 years, most things didn't really change. Or slow was very change. Change was very slow. I think that over the last 10 years, that change has become a lot faster. And I would say even over the last 3 to 4 years, sometimes it feels like things are changing all of the time. I think change is good. I like to try new things. I like to try new ways to do things. I am a perfectionist, and I want, when I give care to a patient, I want that to be a perfect experience. And nobody's perfect, and I know that, but I always strive for that. And I think doctors are, for the most part, what we used to call type A personalities and want things to be as good as they can be.
Yeah.
And I think that the research that we're doing and the studies that we're doing and the data that is being thrown at us now are changing things very dramatically, but for the better. I'll just give you an example. Just use C-sections as an example.
Yeah.
Yes.
I would say that we probably, and research is looking at every single aspect of care prior to that C-section, care during that C-section, and care after that C-section. And for example, what I mean is we're looking at, should people not have anything to eat or drink prior to a C-section? Should they have a protein drink 2 or 3 days prior to that C-section? Will that help them heal better? Will that help their albumin, which is their protein levels, be higher? We look at they do research and studies on, do you shave an area that you're going to make an incision on? How do you shave that area that you're going to make an incision? Do you use a razor? Do you use an electric clipper? Can you do that in the OR? Should that be done an hour before, 2 hours before? What type of incision are you going to make? How long are you going to let the prep dry? What kind of antibiotics are you going to use? What kind of suture do I use? What kind of stitch do I use? Do I put 2 stitches there? Do I put 1 stitch there? Would 3 be better? What are the risks of that? And then even how long does the Foley catheter stay in? When should they start walking? Should they get physical therapy after it? Every single aspect of patient interaction from the 3 days prior to the surgery, through the surgery, and then the postpartum or post-op period is looked at intensely all the time. There's a lot of studies right now on how do you close that C-section scar. Should we use 1 layer? Should we use 2 layers? Should we lock that stitch? Should we do just a running stitch? What kind of suture should we use? It's just looked at over and over and over again in an attempt to perfect that, to prevent infection, to make the hospital stay shorter, to make that care for that patient be the best that it can be. So I think that's how medicine has changed. It's more and more research, more and more attention to detail. How can we make all of these interactions better?
How quickly are you able to act on those changes? Like you hear something, you obviously get it from a reputable place. Does it come from top down? Like, hey, we as a entire academic, institution are going to do it this way? Or is it left up to like doctor discretion in some way?
It's mostly left up to doctor discretion.
Okay.
I will say I work in a large medical institution, which has been great because I'm inundated with all of the new data. But I think we are given a very long leash on there's no one out there saying you absolutely have to do this or not have to do this.
Okay.
And initially, I think there's a lot of things that you can use your discretion on whether you want to.
Well, and like your skill set, do my hands work? I'm just thinking about like the stitches, like, like functionally, can I do this better than I can do this other stitch? And they end up about the same, on the other side. So, okay, that's interesting.
Sometimes there's studies that come out that are absolute, like you really need to give this antibiotic, and that comes down from the top.
Okay.
Some ones that are proven. Have significant safety effects.
Right.
That'll come from top down.
Yeah.
On that note, what is the scariest trend in birth that you're seeing right now?
Woo.
The scariest trend.
Say wild birth. Come on, say it.
So I'm going to go
Don't lead the witness.
Sorry.
I'm going to go a little deep on this. I think that
go deep, Trenia.
There's a lot of distrust in the medical community and in healthcare providers today, unfortunately.
It's a recurring theme.
Correct.
We keep hearing.
Right. And I think probably the scariest trend I see is people shying away from getting medical care.
She said wild birth. She just didn't say it.
There are definitely, I think if you want to go to saying home births and being away from facilities that have healthcare providers, I think that's definitely the scariest trend. And I see the worst of the worst happen. And I think a lot of people don't understand when it's good, it's great, and but it does not always happen that way. And unfortunately, sometimes we see some really bad things that come out of decisions to not have medical people involved.
Yeah.
I find it so heartbreaking when to know people are afraid of us, and we've spent so many years, just wanting outcomes to be better for people, just wanting the best,
right?
And going home at night and worrying about patients and thinking about them long after our interaction.
That's what I was going to ask. The mental load that you carry with all of this. We always ask about that, but like you just mentioned, you've seen scary things. You worry. You think about outcomes and stuff. How does that affect you? Did it affect you more in your previous role, or does it affect you now because you sometimes are called in to like worst case all the time? You know what I mean? What does that feel like to you?
Yeah, I've been doing this a long time. I am I couldn't survive in this field if I took it home with me and if I took this all on my own shoulders. I think I see a lot of bad things happen. I see a lot of great things happen.
Sure.
But I do see a lot of bad things happen. I see a lot of bad outcomes. I have learned that the only way that you survive doing this for a long time is that you have to say to yourself, or I have to say to myself, I did everything that I could do. And if I can say that, then I can go on.
Right.
I can sleep that night and I can go on the next day.
Yeah.
If I took things home with me and I took that on every time, I would never survive in this field. And I do feel that way. If I make a mistake, because I'm not perfect, I do perseverate on that for a long time, and it tears me up inside. But when bad things happen and I am there, as long as I am there doing the best job that I can do and trying to figure out how to fix things the best that I can, then I'm okay with that, because that's all I can do, because I'm just human.
Right. Absolutely. Absolutely.
So we interviewed someone who works with you a lot, an anesthesiologist recently. And she mentioned AI as a tool that you guys are using to predict hemorrhage, potentially, on the labor and delivery unit. They're probably looking at it maybe a little bit closer than you might be looking at it. What other tools do you think AI is going to bring about in the obstetrics? Have you thought about that at all?
I haven't thought about that at all.
I mean, we use models, right? You're already using models, VBAC predictors, success predictors, and things like that. No? You're just flying by the seat of your pants over there, Trenia? Screw AI.
Well, I'm trying to think of how AI could help in
I can't do a vacuum.
No, I mean, AI doesn't have hands, you know.
Right. Not yet.
That just think about obstetrics. It's a very tactile field. You have to have good hands.
For sure.
And it's going to be a while before.
I mean, I think it all would be based on looking at predictions of what is the risk that this person might have an infection.
Right.
You can look at you can put them in all different types of models of what's their BMI, how long were they in labor, when did their water break, all those things could eventually go into some type of program to predict what's their chance of infection. I think we have a calculator that we use that's called a VBAC or a TOLAC calculator, and we put in
you said TOLAC. I'm sorry, I have to interrupt you. What is that?
Trial of labor after cesarean.
Right. It's someone who wants to have a vaginal delivery after they had a prior C-section.
Gotcha.
And we have a calculator that we put different factors into, like how long ago was their C-section? Why did they have their C-section? What's their BMI? Different things like that. And it will give us a number, a prediction of how successful their vaginal delivery will be.
Yep.
Although I will say and why I kind of hesitate on that on the AI question is because there are so many different variables as to why things happen to certain people. I think I'll go deep again. I think in having a baby is such an emotionally charged process, and it is a life-changing event for people. And I think a lot of people come into that process with an idea in their mind about how they want their birth process to go.
Yes.
And what they don't understand is that there's a lot of variables that go into that.
Yeah.
And they may have had a cousin that they've known for years that had a birth experience, and they tell them, well, this is what happened to me.
Yes,
and they come in and they're like, well, why did I get an infection?
Yes.
And what they don't understand is there's 1,000 different things that may lead to the outcome that you have having a baby.
Which is why you need a doctor who can know all those things. And
it's hard for us to even tell you about those things. These are things that have been studied for years and years and years, and that we try to perfect, but we don't have the ability to perfect them. But that's my worry about AI is AI doesn't always understand that there are other variables to that.
Yeah, great point. What about social media and the internet? We've talked a little bit about that with just the fear of medicine and obstetricians in general. But even positive sides?
I don't really have any positive.
Anything that you have to work around? Any specific like any specific phrases you have to say over and over? To
say wild
speeches,
birth again.
Speeches that you have to
Here's
combat
what I'll
social
say
media.
about social media.
Yeah.
Social media has been extremely detrimental to the medical field and to healthcare. The trust, the mistrust that's out there.
Yeah.
And I think I'll say my personal opinion is that a lot of that comes from the inaccuracy of postings that people will put on social media.
Yes.
And I don't know that it's necessarily always inaccurate because of an intentional inaccuracy. I think a lot of times it's just a misunderstanding or not understanding fully. And just like I just said, there's some people, they have an idea of how things should go, and if it doesn't go that way, sometimes they don't always understand why it didn't go. And we can stand there and say 1,000 different reasons why did you have to have a C-section? Why did my cousin not have a C-section and I had to have a C-section? Well, how was the baby positioned in your abdomen?
Right.
And what's the shape of your pelvis? And what type of tissue do you have?
Right.
How much
and
collagen
20 years
do you
ago,
have?
all you would have known about was your cousin.
Right.
But now you know about people
Influencer
all
ABC.
over the world. Yes.
Right.
So you can compare that way, which I'm sure is just one more thing to wade through, right?
Right. I think that back on the social media, I think a lot of things that people put on social media, just like anything else, is always the good side of it. I think a lot of people will see they have their makeup on and there's the pretty baby there and everything looks good, and they don't post the 12 hours of the screaming and no makeup and the pain and some of the things they go through. So I think a lot of that might be misleading. I think there's also a lot of misunderstanding. A lot of the drugs we use are in social media are trampled, and they're actually drugs that have been tested for years and years and years.
Yes.
And there's a large distrust for, we'll just say, Pitocin. And I can say that your body makes Pitocin.
Yeah.
And some postings will say, I don't want you, or some people will say, I don't want you to use Pitocin because that's going to harm my baby. But that could be no farther from the truth. Like, I would never give you a medicine that could harm your baby. Or they'll say, Pitocin leads to C-sections. Well, Pitocin doesn't lead to C-sections. Pitocin leads to contractions.
Yes.
And sometimes contractions get very strong, and fetal heart tracings may not look as good when your contractions are strong. And so there's many things that lead to C-sections. The drug alone is not the cause. So I think a lot of it's social media has opinions that are not always accurate, and I think that they lead people to believe things that are not always true. And I think sometimes that leads to a distrust of medical people.
Yeah, I think one thing that I have picked up just in doing these episodes so far, I think, Lara, you said it, was like, if you watch something on social media, make sure you watch all the way to the end and see what they're trying to sell you, because they might be telling you something at the beginning that you're like, oh, that makes sense. Okay. But then when you get to and you can learn more in my downloadable tutorial on blah, 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 then you got to go, oh, okay. Like, it may not be untrue what they said, but it also
it's not an unbiased set of data.
You lose your credibility when you have a product.
Right. Which, like, social media is a lot of cases a business, and it's how these people are supporting themselves. So it's like this dance you have to do, which is why you should have a doctor that you trust, that you can say, I saw this. What does that mean? You know what I mean? And I feel like y'all are the ones we've met are very good to be like, I understand you saw that. Here's what you need to know, And so that's just a little PSA. If somebody's selling something, just think twice.
It's a helpful filter.
Yes, it's like a judge.
Age-old advice,
Trenia, your field is unique in that you have 2 patients simultaneously. It's really hard to imagine any other field like this. where you're monitoring two. Two monitoring, two that you're protecting, and then at times two that you're rescuing. And they're not always going the same direction at the same time. Walk us through that a little bit.
I'll say when a woman comes in labor or comes in a trauma, I think that there's always more anxiety from many of the other specialists, especially like if there's a trauma, the trauma surgeons are, there's a lot of heightened anxiety around that because there are two patients. And I've done this for years, so I'm used to that. But it does change the dynamics dramatically because you have to think of a pregnant woman, her physiology is actually different than someone who's not pregnant.
Right.
So you have to understand the physiology of it as well. And you have to also understand that there's a fetus that you have to protect as well. So there's it does heighten the anxiety when someone comes in that is pregnant in any type of medical emergency. You have to always consider mom and you have to always consider baby.
Is that the scariest? Is that when you get scared? Like, do you ever get scared when you're in those situations? Like, I know you present as a very confident. I know that's what I'm saying. You present very confident, which is great, but like,
I try to teach the residents that it doesn't matter what situation you're in, you never let them know you're scared.
Sure.
Sure,
but are you
I
really?
get scared.
Okay. That's all I need to know.
There are definitely situations that are
because you're
very
human.
scary.
Like if I'm trying to take care of two living children at the same time, that gets scary because I'm like, I don't know which one, if like with my two children, like,
right.
I can't even imagine it being a true like in life and death situation. That's 10,000 times what I
think
have to do.
sometimes you have to turn that off, though. I think you just have to figure out, how do I make this better? What do I need to do? And you have to look at it through the medical eyes and say, what are we going to do now?
Sure.
What do we do next? How do we
the
stop
next
this
right thing?
bleeding?
That's what our anesthesiologist said.
That's what
do the next right thing.
Yeah,
yep.
That's what your training gave you.
Yeah.
The ability to.
What about when the speaking patient makes a decision that will threaten potentially the patient that is not able to speak for themselves?
Wow, that's crazy. So I do encounter this quite often. I think the way that we approach it is counseling.
Is it usually they don't want you to intervene in some way?
Correct.
And they think it's because this reason it will be better. Correct. And you know that that's not the truth, probably.
Sometimes it's cultural.
Okay, sure.
There are, we see people from all different places over the world, and sometimes there's cultural issues that come into play. Sometimes it's fear, sometimes it's ignorance.
Exhaustion. I
feel sometimes it's exhaustion. Like I said, having a baby is it's a very emotionally charged event. And I think I would say probably just like an example of telling someone you need to have a C-section and they say, I don't want to have a C-section. I can't do a C-section on that person. That's assault. So what I tried, I don't want to give all my secrets away. What I will say that what we do and what we teach the residents to do is you go talk to that patient and you try to find out what their fears are.
Yeah.
And you try to connect with them in an emotional and just as a person and a human. Like, I'm here to help you. Tell me what you're scared of.
Right.
And why don't you want to do this? And you tell them the risk. And I tell them I'm not trying to scare you and I don't want to upset you, but I want you to understand this. And then I usually give them some time and I say, look, you just talk amongst yourselves.
Yeah.
And I'm not going to force you to do anything that you don't want to do. That's not what I'm there for. I'm there to take care of people. I'm not there to make them do things that they don't want to do.
Sure.
So we talk to them, and I tell the residents, you talk to them, and you give them the risks, and you respect what their decision is. And I can't make someone do something, and at the point that the fetus is inside of the mom, I can't make her do what I think is best all the time.
Right.
But And then we go back and then we talk to them some more.
Yeah.
And then we go back and we talk to them some more. And in most cases, eventually after, if they think maybe I will change, my cervix will change some more, or
right,
things
when
will
nothing has
change. And I will sometimes bargain with them a little bit, and I'll say, okay, I hear what your desires are. I know what you want, and
Right.
I try to connect with them, and I say, look,
I'll give you one more hour.
let's
or I'll
give it
you
another 30 minutes,
Yeah.
and see how things look. And what are your thoughts if we give it some more time? And I think sometimes you're trying to just meet them halfway. And that's all you're asking from them. I know that coming to where I want you to be is a long way to get there sometimes, right?
Yeah.
So if you can just bring them a little closer and then bring them a little closer. So a lot of it is just talking and going back and talking and going back.
Yeah.
And most of the time we meet in the middle at some point.
Okay. That's good to know. Yeah.
All right, I'm going to ask you a political question, but only in the obstetrics OB-GYN world. All right, so our specialty, Lara and I know this, Courtney may not know this, that there's a lot of discussion about training because we've become very super specialized, and Trina's an excellent example of that.
Yes.
Where she let go part of it and focuses. And Lara and I did the same thing, where we let go part of it. And so as we've progressed in our subspecialization, there's a lot of talk about splitting OB and GYN into separate fields.
Yeah.
Yes.
So from the get-go,
From-
you only
yeah.
do one.
Yes, from the get-go. And so I'm curious what Trina thinks about that.
There's a lot of
If
different
you
opinions.
want
Making a
to,
face.
if you want to weigh in, you don't have to.
No, you have to weigh in.
Say wild birth and weigh in. Come on, Trina.
I may not be very popular amongst some of my peers, but I would be in full support of that.
Of splitting?
Of splitting.
Oh,
Yes.
interesting.
That is interesting.
What about you, Lara?
Oh, I'm there too.
Splitting?
I think it's
I'm the
past time.
opposite. I'm keep
Are
it
you?
together.
Really?
Oh.
Yes.
I
but
think it's past
yeah.
time.
The reason is,
What would you do as a patient? This is my question.
I would
I
like
have to go 2 times a year? Oh, my word.
No, you would only
don't
see
see
the
it.
obstetrician
You only
when you're
see an
pregnant.
obstetrician when you need,
And then you would see the gynecologist the rest of the time. Yeah, so it would truly
I
be
have
split.
thoughts about that.
But yeah.
Let's hear him.
But we'll hear Courtney's thoughts. So my thought, here's why. There have been so many things that I needed to do during a GYN surgery that I was so glad my hands had the tactile learning that they did during obstetrics, placing IUPCs and fetal scalps and feeling scalp position and, station and effacement.
Wiggling an arm
it's
down.
its own education of your hands. That you don't even realize is happening when you're doing those hundreds of exams on laboring women and putting in those things, around a fetal head that you're trying to be very careful. So now I can put in an IUD by feel if I had to,
Sure.
or a uterine manipulator or things that are just really difficult sometimes in the operating room. I have a skill set I don't think I ever would have gained.
Because you wouldn't do it as much. if
Right,
you were
because we just
doing-
pointed out
Okay.
having a huge exposure in a short period of time
Yeah.
exponentially increases your skill set in something. And I feel like the tactile sensation is one of those things. But I would add a 5th year.
Well, I was gonna
that would
say
be the
that.
trade-off.
I was going to
like
say
it,
that.
yeah.
I would change it to
go longer.
I feel like coming from my side of it, and Laura's on my side, just by the way.
I'll be the judge.
I feel like
the arbitrator.
You'll decide.
That-
We're on the whole country.
I feel like the field is too large when you
that's
put
what
them
I feel.
together.
It's just too much now.
It's so much.
It's so much. I
hard
feel like,
keep up
and like I said, if you were paying attention to the things that are changing, that so much is changing so fast. It is very hard to keep up with all of that. If you're trying to do both obstetrics and
just
gynecology,
going
for me,
wider,
it was
not deeper.
overwhelming
Yeah.
trying to keep up with all of the changes. When things are changing, sometimes monthly,
Yeah.
multiple things changing monthly. So I just feel like the fields are so large that splitting them into a gynecology side where it's just women's health, annual exams,
Okay.
birth control,
Yeah.
menopause,
Sure.
perimenopause, sexual health. That field in of itself is
It's already full.
Is huge
ginormous.
already.
Yeah.
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 and then obstetrics
Not to
is
mention the
becoming
surgical
that
side.
way. Obstetrics is also it's a different world an obstetric patient is very different than a gynecological
Well, and
patient.
then I'm thinking back to what you were talking about how you're seeing patients at 3 weeks instead of 6 weeks, and you can talk more about the postpartum. You would have more room. I mean, not that you'll have all the room, but you know what I mean? You'd have more room on that if you were an OB specialist person, whatever,
right.
Obstetrician only, then you would have more room to like go into those things with patients.
Right.
Oh, I don't know what to choose.
Look, you and
Because I have known, here's what it is. I have known women get pregnant, planned and all the things, and have such a hard time getting in to see she was with because I have doctors that after a while they were like, nope, I'm not delivering any more babies. I am done with that. Yeah. Mm-hmm. And so that's who she was going to. And whether or not that was a good choice for someone of her age, I don't know, because she had not yet had children. So like in the front end, like you need to make sure. But if you're she had to wait. I think she didn't even see a person until, I feel like 3 months. I don't know. It was in my mind, I was like, this so far into it. And so that would be my only concern, is that you would delay care if you had to wait to get into an obstetrician. So I don't know how to make it to where, because like when I had, I was going to an OB-GYN. I got pregnant, called them. They said, come see us at 6 weeks.
You were already established.
I was already an established patient.
Yeah.
It wasn't a hard thing to get into
access is your
there.
concern.
Yeah, that would be my
Well, I would say
only question.
if you took away the gynecology part in the annual exams,
The OB would have more appointments.
OB would have
Okay,
lot
it's a
of
valid
openings
argument.
because they're no longer using their time to do.
Yeah. It feels like obstetrics is like happening. I'm jumping up and down in my seat. Like it's like, there's always something going on. There's always something going on.
Yeah.
But if you're like gynecologist, it's not as
We're just sitting in our rocking chairs.
Every day.
You want a pap? Here's the exam. Here we go. Yeah. So yes. Okay. Well,
You're very perceptive.
I can see it. I've been a patient a few times. So I can see it a couple of ways.
well, I think
calling her a
I would
professional
say
patient.
availability would grow.
Would
Okay.
change, yeah.
If
The
you
entry
separate
pass would change.
But I will say, I'll tell you, it's been obstetrics and gynecology for a long time. This has been discussed for years. This is not an easy decision.
Yeah.
And,
Do most
there's
people in med school go in thinking, I'm going to do both because you do both, but this is what I really like?
I think probably
Or do people
so.
switch?
I think probably so.
Okay, you think somebody's like, I love
now
delivering babies.
They meet people like me, and they meet people like Dr. Junker, and they meet people. When I was going through, I didn't have that. There were obstetrician gynecologists. They see a lot more of specialization.
Yeah.
So I think that it is more medical students are saying, I would rather be a gynecologist, and I don't like OB.
Yeah.
I can't imagine that, but I think.
Who would think that?
But I also think I definitely have residents that come to me that say, I don't enjoy gynecology. I would really like to do obstetrics. So I do think that we're seeing more and more of this. I don't know if they will ever split the residency, but
you make a good argument.
I think there are good arguments on both sides of it.
Well, and I would love for all women, this is another PSA I'm just going to put out there, to go see a primary care physician, because so many of us only go see our OB-GYN, and that is our only doctor that we ever see. And I used to do that too. And I would talk to my doctor about random things, and he'd be like, oh, you're doing fine. And I'm always like, and I was doing fine because I was young, but like I would have loved a lot more,
more depth.
Well, I would say as much as medicine's changing, you should definitely have a primary care physician, because obstetrician and gynecologists do not keep up with how do you manage blood pressure correctly.
Yes, so
there's too many things changing.
So that's my PSA for anyone listening. Please make a primary care appointment right now.
Good for you. It's a good PSA. Okay, we're coming up on our speed rounds. Okay, so we're going to ask some fun questions. These are kind of quick, top of your head answers. Okay,
I'm not good at those.
I
might say,
It's okay.
It's all right.
My husband told me I said too much too, so I'm trying to. He said, you need to stop the and. Okay, sorry. It's all right. He's the editor.
Number one, are you superstitious?
No.
No one is superstitious.
Wow.
Lara
I'm
and I
so
the only
surprised.
ones. Oh, really?
I'm horribly
Do you
superstitious
say the
about
Q
Paul.
word when you're at work?
What's the
I probably
Q
don't
word?
say the keyword.
Okay, then you're superstitious.
Mildly
Q word. Wait.
superstitious.
I
would say-
or the S word, which is.
Okay.
I bet you she doesn't say either one of those when
gotcha.
she's a
I
word.
gotcha.
I don't say that.
Okay.
And they won't let me wear a red shirt either because they say that makes you
It
have
really that
hemorrhages.
makes it
Well, there we are. She is.
interesting.
But I would wear a
What?
red shirt. They say that if you wear red,
they?
The nurses,
nurses?
and people
Oh.
at work on labor and delivery.
We need to get
that
nurses in here. Are
If
they
you have a bad
superstitious?
hemorrhage, they're like, "Who has on red?"
Oh my gosh, that's funny.
That's so interesting.
I've never heard that.
So I don't wear
heard that
red,
either.
but I would wear red. I would
Okay,
think that
okay,
counts.
Just for local comfort, you're like, oh,
Okay.
Just afraid of the
You're
nurses.
fitting in with the culture. What other specialty do you ask for help the most from? Would you say?
General surgery.
Okay,
Oh.
that's a good one. What's a word or phrase you end up saying multiple times a day? We all have our little scripts. What do you end up saying over and over again?
Oh wow, I'm gonna have to think about this one. Push.
You didn't have to think very long.
Yeah.
Do you know what? I do a lot of surgery with the residents, and I think that I say over and over again, don't try to be fast, be efficient.
That's a good one. Yeah, because that's how you
I say
become
that a
fast.
lot.
Yeah.
Because I
eventually.
see a lot of them trying to go fast, and I go, you're just slowing yourself down trying to go fast. And then people will tell them, you need to speed up. And I'm like, it's not about speeding up. It's about being efficient with your movements. So I say that a lot. Be efficient, not fast.
That's good. I like that one.
You can use it.
I might
take-
steal
all
it.
right.
I might just steal that one. Who in your inner work circle could you not live without?
My nurse midwives.
Okay.
Oh.
Yeah.
Good.
I work a lot with nurse midwives.
That's great. I wish that had been around when I was having children.
They're
it was
great.
not.
They're great.
It was still kind of like, oh, what's
I'm
that?
glad you have a very collegial relationship with
Yeah.
them.
It's great.
They see they're trained a little bit differently, and they see things a little bit differently, and so they add it's that we complement each other very well.
Yeah, like a meeting of the minds. It's great.
Yeah. I think it's a good model for.
Very good model.
If you could ask your boss or chair for one thing, what would it be?
It can be anything, like Skittles. Do you want Skittles? Do you want?
Never ending bowl of
Do you want less air conditioning?
If
more
I
air
could have
conditioning?
anything 100% honest, I would love to move labor and delivery closer to the children's hospital and have just a women's area.
Yeah, yeah.
That- if I could have
Oh.
anything, I wanted had all the money in the world, I would have a women's
hospital. Nice.
or a women's wing.
Yeah.
Wow,
Yeah.
that would be groundbreaking.
It's a long
Literally.
trot between them.
If you build it, they will come.
They will, for
There's
sure.
no shortage of patience.
What other medical specialties gross you out?
Anesthesia kind of grosses me out. It's the mucus.
It's the secretions.
That's so funny.
Courtney
so
is
funny.
tired of us talking about
can't
mucus and secretions.
We've
But
all
it's-
got one. We've all got one. Would you encourage your children to pursue a career in medicine?
100%.
I love it. Tell us more. Are any of them interested,
My-
you think, or are they going that way?
My daughter, I was coming home from softball practice the other day, and I couldn't make it home, so I said, you have to go to the hospital with me. She's 13. And she's always said, I think I want to be a doctor. And I took her to the hospital and took her on a tour, and she is like, she's bought and sold.
Oh, I thought you were going to say the opposite.
Loved
Okay.
everything about it and got so excited about it. And I was telling her about things, and she's like, I have no idea what you just said, but that is the coolest thing I've ever heard in my life. And so, yeah, I would. I think medicine is a very, very, very emotionally, mentally, physically hard route to take, but I have never once looked back. I love what I do, and I would do it again in a heartbeat. But it's hard to get there. So
a
get
long
ready
road.
for the battle. But I love what I do.
I love that. The future of medicine is in good hands. Do you have a joke about your area of medicine?
A clean one.
Nothing in labor and delivery is clean. That's gross.
I don't know a joke that I have.
Okay.
No.
Okay.
I'll think about it.
That's
See
all
if one
right.
comes to
Okay.
mind. They're all dirty.
That's funny. Is there any piece of advice, I feel like we didn't ask this question, that you would give a patient about their pregnancy?
About their pregnancy.
Like a woman out there is pregnant right now, and she's listening, and she's wondering, what in the world? What's a hospitalist? What is that? I don't want that. What is it? What would you tell her about labor and delivery or whatever? What would you tell her?
I think my best piece of advice for someone who is pregnant is to have as their one and most important goal to stay healthy and have a healthy baby. Don't focus so much on how you get there. Don't focus so much on the pregnancy itself of, I have pain here or I have this here. And don't focus so much on the birthing experience and the birth plan that they envision in their head. Just have as their most important goal to be healthy and to keep their baby healthy. That would be my biggest piece of advice.
Yeah. Okay, now our favorite question.
This is it. The
This
finale.
is it. If you could do any job in the world, any job outside of medicine, and still support yourself, you don't have to go back to school for it. You just wake up and you've got the knowledge, whatever it is. What would you do? Not medicine.
I would be a homicide investigator.
You would be
love
so good
like
at that,
podcasts and stuff.
Would you
Is that
wear
what
red?
love?
I would absolutely wear red every day. I absolutely am enthralled and obsessed with like crime dramas and
True crime, or do
true
you like
crime,
the
true crime.
do you like the
Fictional.
dramatic ones?
No,
You're not a Law and
true
Order
crime.
dum-dum
I love
person or whatever.
Dateline and 2020. And
I can't even watch that.
I
I
am
can't.
fascinated by
It's
that.
always the husband.
If I listen to one, I think everyone's going to kill me. Like I literally be sitting here right now going, which one of you?
I feel like
Which one of you is going to
Who's the
gonna take me in that closet over there?
It's the quiet ones.
Yeah. Oh no.
No, but I would love to be a homicide detective. I don't think that they would hire me at my age, but I think it would be fun.
You never
I think
You
it
had
would
the
be
knowledge.
very
Why not?
interesting.
Yeah.
Yeah.
Okay.
It would be
Fascinating.
interesting.
Thanks, Trina.
Thanks for having me.
Yeah.
Great job.
This was great. You did
It was
great.
fun.
Yeah, so fun. Well, we want to thank all of you for listening, and we hope that you are following along with us on Instagram, and we'll be back soon.
Bye.
Bye, everybody.
Bye. This podcast is intended for informational and educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. The views and opinions expressed by the hosts and guests are their own and do not constitute medical guidance for any individual case. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or health concern. Never disregard professional medical advice or delay seeking it because of something you have heard on this podcast. By listening to this podcast, you acknowledge that the host, guests, and producers are not responsible for any decisions or actions you take based on the information discussed.